Hi there. My name is Dr. Jeannie Cavillo, and boy, oh boy, have we got some amazing information to share from our seminal study, which establishes the first commercial rate benchmarks ever reported for CRNAs under the QZ modifier. We then compare the CRNA rates with the anesthesiologist to see if there's any disparity. But we don't stop there. I mean, seriously? Once we had those results, we simply had to see exactly what the impact could possibly be on our cost efficiency modeling. So we decided to form a little simulation of our own to see what happens when commercial payers reimburse CRNAs significantly less than anesthesiologists when providing essentially the same service. Our research team includes Dr. Jeannie Skibitsky, Dr. Sally Pepsel, and the Lewin Group. And we would like to extend our thanks to the AANA Foundation for the generous grant funding that made this study possible. Most of the information shown today has never before been seen, so you might want to buckle up. Before we get started, I'd like to give you a little background as to why I felt this study was so important. I've been a practicing CRNA for about 30 years, with about 26 of them spent establishing XL Anesthesia, which is an all CRNA practice. And our group consists of about 25 phenomenal CRNAs who provide independent services to more than about 30 facilities located in the Kansas, Missouri area. And the majority of our revenue comes from fee-for-service. But since about 70% of our payer mix is Medicare, we rely heavily on the commercial payers to offset the lower Medicare rates. Yet commercial payers insist on reimbursing us at about 70% of the rates compared to the other physician-led groups in town. And I know what they're getting because I've had procedures at these facilities and I've reviewed the allowable charge. So we've reached the point in our practice where the reduced revenue coupled with rising CRNA salaries has really hindered our ability to match salary packages when recruiting staff. And we contract with most of the commercial payers in these states. And of course, one of the first steps in contract negotiation is to perform market research to see what the prevailing rates are in the area. But guess what? There aren't any benchmarks established for CRNA services. The only benchmarks are provided through the ASA yearly commercial rate surveys. And you might not know this, but the ASA benchmarks do not reflect CRNA reimbursement. They're only reflective of physician-led practices, and the rate is often specific to the medical direction delivery model. CRNAs are not asked to participate in these surveys, and no distinction is made for the CRNA billing modifier QZ. Now, I can't speak for your practice, but I can tell you that these rates have always been about 30% higher than ours. And this got me wondering why. I mean, we know that the law requires, as stated in the Affordable Care Act, payers to base payment valuation on quality and performance rather than licensure. But none of the other CRNA groups believed that this was actually happening, and neither did I. If it were, our group would be at the top of the pay scale, since we've always excelled in the merit-based performance scores, which is how quality and performance are measured. But here's the thing. It isn't enough to know or think you're being treated unfairly. You need to be able to prove it and then quantify it. This is the reason why we decided to do this study. And although the study involved a small number and bigger efforts are needed to more accurately quantify the disparities, the report is significant in its findings of disparity and discrimination, which proves the most important thing, that disparity does exist, which provides the evidentiary basis that supports the priority of enforcing regulatory compliance to ensure markets remain free and competitive. The objective of this study was three-pronged. The first, to establish commercial rate benchmarks specific to the CRNA anesthesia delivery model, or QZ. The second, provide rate comparisons to quantify any disparities that may exist. And the third, to use these findings to determine payer alignment with non-discrimination provisions of the Affordable Care Act. The next 3 slides provide a brief anesthesia billing overview. So if this is something that you're already familiar with, you can skip ahead to about the 12.5 or 13-minute mark on this video to get you to the design and methodology slide. We will begin this review by discussing Medicare rules and fee calculations. Anesthesia procedures are reimbursed by the total billable units. There are base units, modifier units, and time units. Medicare assigns each procedure with a number of base units. The total units assigned are dependent on the complexity of the procedure itself. Base units are typically between 4 and 12. However, more complex procedures such as liver transplants can be more than 30. Time units are typically defined in minutes. Medicare allows 1 unit for each 15-minute increment of time, so an hour-long procedure would include 4 time units. Commercial payers may define time units in different increments, such as 8 minutes, 10, 12, and also 15 minutes. Modifier units are added in certain conditions that add complexity to the procedure. So a class ASA 3 or 4 patient, for example, could add 1 to 2 modifying units. Medicare does not typically recognize modifiers, but many commercial payers do. The anesthesia fee is calculated by multiplying the sum of the total billable units by a conversion factor to establish the charge. The conversion factor is known as the rate or dollar amount assigned to 1 unit of work. CMS conversion factors are set annually. This rate has hovered around the $20 to $22 range for about the past 10 to 15 years, depending on your geographical location. The Medicare conversion factor is a universal conversion factor that applies equally to all anesthesia providers. The total billable units is the number of units recognized by Medicare for reimbursement, and typically the total billable units is equivalent to the total units. However, I will show you instances where units can be capped. And this is the basics of the anesthesia charge. The reimbursement, on the other hand, varies, and it's dependent on the rules associated with the delivery model itself and the payer. So let's talk about delivery models. I know this is a busy slide, but bear with me because this table provides a snapshot of the Medicare reimbursement rules associated with the 4 anesthesia delivery models. Although Medicare sets a universal reimbursement rate, also known as the conversion factor, that's the same for physicians and CRNAs alike, the payment allocation and the number of units recognized for reimbursement depends on the specific delivery model used. The first column of this table shows the 4 delivery models: CRNA alone, anesthesiologist alone, medical direction, and medical supervision. And then the next 2 columns over show the code associated with the type of provider participating in the model and the percentage of payment that Medicare pays for each provider based on the delivery model. When submitting a claim for anesthesia services, these codes inform the payer of 3 important things: the type of provider, whether you're a physician or a CRNA, the delivery model used, and the percentage of the payment allocated to each provider. The QZ code is unique to the CRNA, and it's the only code used when CRNAs provide anesthesia services alone without medical direction. So it is uniquely associated with CRNA non-medically directed services. The percent payment shows the amount each provider receives of the total billable units. And since the top 2 models involve only 1 provider, CRNA alone and anesthesiologist alone, it follows that 100% of the payment for the units of work provided goes to 1 provider. When billing Medicare, both CRNAs and anesthesiologists are reimbursed at the same universal rate per unit for services provided. Regardless of which provider performs the services, they both are recognized to receive the same payment for 100% of the units of work provided. If you turn to medical direction, you see the payment is equally split 50-50 between the anesthesiologist and the CRNA. And this means that both are reimbursed for 50% of the total billable units. But Medicare places conditions on the physician portion of the payment in this delivery model. Anesthesiologists may medically direct up to 4 qualified providers in concurrent procedures as long as they can show they have completed the 7 TEFRA steps. Sorry, you heard my dog, Trinity. These steps were named after the Tax Equity and Fiscal Responsibility Act was passed in 1982 by Congress to address runaway spending on health care. The 7 TEFRA steps are: 1. Perform a pre-anesthetic examination and evaluation. 2. Prescribe the anesthesia plan. 3. Personally participate in the most demanding procedures in the anesthesia plan, including induction and emergence, if applicable. 4, ensure that any procedure that he or she does not perform are performed by a qualified individual. 5, monitor the course of anesthesia administration at frequent intervals. 6, remain physically present and available for immediate diagnosis and treatment of emergencies. And finally, 7, provide post-anesthesia care. Now, this is important. These steps are not to be confused with standard of care, okay? Instead, they are merely required to show that the physician was sufficiently involved to warrant payment for the services billed. If the physician cannot show evidence of this level of commitment, the delivery model must be reclassified to another delivery model, such as medical supervision or QZ. And this makes sense, right? Because QZ is by default non-medically directed. So if the 7 TEFRA steps cannot be completed, then therefore the CRNA has not been medically directed. And this claim can be reclassified under the QZ, where they can still receive 100% of the units in the total billable units. They can receive payment for all of them. Medical supervision, on the other hand, is when an anesthesiologist is supervising more than 4 CRNAs, or when medical direction fails the criteria for payment, fails the TEFRA steps. This delivery model caps the physician base units at 3 and allows for 1 more if they are present on induction. So if you're doing a case involving medical direction that fails the criteria to bill it and the total units exceeds 6 or 8, you would certainly not want to submit that claim under the supervision modifier because you would lose billable units. This is one reason why QZ utilization has increased over the years. This is a quick summary of differences between Medicare and commercial payers. The biggest difference is that the rates in Medicare are universal, which means all providers are reimbursed the same, while commercial payers negotiate separate rates for each contract. Since Medicare rates are universal, benchmarks are not applicable. Commercial benchmarks have been established by the ASA surveys, but no benchmarks for CRNAs have been available until we recently established them through this study. Non-disclosure agreements are present when contracting with commercial payers, and the reason payers enforce these agreements is to prevent price fixing. But another benefit for payers is that the transactional secrecy effectively keeps evidence of discrimination from ever seeing the light of day, potentially leaving whole classes of providers vulnerable with little evidence to prove bad behavior has occurred. The only way to get around this is by doing surveys like this one. The Affordable Care Act non-discrimination provision requires payers to value reimbursement by quality and performance. So let's see if it looks like they are. So this is an exploratory descriptive study that relies on a targeted population. And prior to commencing this study, there was no known database available that targeted CRNAs working in fee-for-service settings from which to survey. So we developed a database from the ground up for use in our samples framework in a separate study entitled the CRNA Fee-for-Service Database. Now, this database was comprised of 345 CRNAs with experience in payer contract negotiations, or they had access to QZ claims data. Survey links were sent by direct email to the 345 individuals in the fee-for-service database. Other participants were also recruited via private social media groups focused on billing and reimbursement. The survey instrument was separated into 2 sections. Section 1 focused on commercial rates of the top 5 commercial contracts. The survey mirrored ASA questions and methods of calculations. And this is especially important, and we will go into that a little further in the next slide. Section 2 focused on other contributing factors associated with CRNA contract negotiations. I'd like to take a moment to point out a few things regarding the QZ survey tool design. This section was designed to closely match the ASA surveys for comparison purposes. So, with the exception of the focus on QZ, both surveys were similarly set up. Both asked for rates associated with the top 5 commercial payer contracts by unit volume for cases performed in 2019. All units were normalized to a 15-minute interval using the same adjustment methods. Both surveys relied on the Medical Group Management Association for the allocation of states to specific regions, and data analysis and table presentation were similar. Lastly, both surveys complied with the DOJ and FTC requirements when calculating rates and reporting averages. These conditions are explained a little better in the next slide. The study complied with principles established by the DOJ and FTC, which required the data to be at least 3 months old, and 3 conditions had to be met. The first, at least 5 respondents were required when reporting on each statistic. The second, no individual could account for more than 25% of the data reported in rates. The third, the information had to be disseminated in such a way as to preserve anonymity. Now, these principles are set up to protect anonymity and allow businesses to see what the prevailing rates are without breaking any non-disclosure agreements. There were a total of 41 respondents, which may not sound like a lot, but you need to understand that they were reporting on behalf of more than 1,089 CRNAs, and 56% of these CRNAs worked in mixed practice settings alongside anesthesiologists, while 44% identified as working in solo practices. The data was reported for 351,920 claims, of which 127,888 were identified as commercial. Regional commercial claims totaled 118,138, which is less than the overall claims reported, because one respondent did not assign a regional location or provide the number of CRNAs in the survey response. So as a result, 9,750 cases and 1 contract, among other variables identified, were excluded from regional tables. Another respondent reported commercial data that spanned 2 regions. Other variations in regional data sets were similarly seen due to incomplete responses to questions pertaining to region, contracts, and number of CRNAs. Because of this, adjustments were made in regional tables to properly represent the data reported by both regions. So there were 144 unique contracts identified, and the contracts eligible for rate calculations varied based on the information provided and the DOJ FTC criteria. Contracts originally eligible for rate analysis prior to exclusions or adjustments were 139, while 144 were often eligible for other questions unrelated to rate. This slide shows the payer distribution of cases and units. One respondent reported 92,400 claims, of which 34,300 were commercial. Now, this number made up more than 25% of the data overall, and as such was ineligible to participate in rate calculations due to the DOJ conditions. Think about this for a minute. 34,300 cases, more than a quarter of our data, had to be eliminated from rate calculations because we didn't have enough respondents. In contrast, the ASA 2019 survey reported 9,258,000 commercial cases. So you can see how these conditions can play a significant role in reporting when sample size is small, and we will see that as we move forward in the tables. This graphic shows the regional allocation of cases and the percentage each region contributed to the total. The southern region accounted for 49% of all the data, with 62,890 cases, followed by the Midwestern region with 19% and 24,881 cases, with the Western region close behind with 18% and 22,419 cases, and the Eastern contributing 6% with 7,940 cases. Notice there is 8% that were unidentified in regions, which accounted for that 9,750 cases. This graphic reports the breakout of mixed practice versus solo practice settings. Of the 1,089 CRNAs claims reported, 44% reported as solo practitioners working alone or for a CRNA group, while 56% were from mixed practice settings working alongside anesthesiologists. These mixed practice settings reported that 68% of all billings submitted involved QZ services. Both the southern and western regions reported higher percentages of mixed practice settings, while the Midwestern region showed higher percentages of solo practice settings. We now begin to build on data that we've already presented. So we're looking now to the managed care summary by region, and this table easily shows the high and lows by region for the variables shown. We previously displayed the total CRNAs and cases by region, but this summary includes them here as well. The number of contracts, units, and managed care are provided here. Contracts, nearly half of 41 respondents reported 5 contracts, with a total of 144 unique commercial contracts included in results. Remember, some of these respondents may have had more than 5, but the survey only asked for 5 contracts. Mean units per case nationally were 8.9, with the Southern reporting the highest at 9.2 units per case, and the Eastern region averaging the lowest at 6.1. The highest number of managed care contracts reported were by the Midwestern region with 58, with the low of 12 reported by the Eastern region. Overall, commercial contracts contributed 35% of managed care business, with the Midwestern region reporting the highest percentage of managed care at 44.52%, and the Eastern region reporting the lowest at 25%. So now let's check out the results from Section 1 that show the average commercial QZ rates. The national commercial rates per unit are shown as a weighted normalized mean across all contracts and by each individual contract. Now, this is the only time we'll be able to show averages by each specific contract due to the FTC DOJ restrictions in reporting. All other regional tables are only able to show the overall average. The ASA survey, on the other hand, had a much larger sample size and was able to break each region out with averages by contract. But we began with the normalized weighted mean rate across all contracts, which was $58.62 per unit, ranging from $55.33 to $64.57 across contracts 1 through 5. This result relies on 137 eligible contracts from the original 144. 5 were excluded as outliers, 1 was excluded due to missing information for contract rates, and 1 contract had to be excluded from the overall mean calculations. And again, this was because that person's data contributed slightly more than 25% of the data in the study, as we discussed. But had we just had 1 more respondent, this data could have been included, and it might have reduced the overall mean down to about $56 per unit. All remaining calculations are based on the 135 eligible contracts, since 2 more, in addition to the 1 seen in the overall mean, were suppressed under contracts 1, 2, and 4 in compliance with DOJ regulations. The minimum rate was $22.68, and although this looks like it could have been an error since it very closely matches Medicare rates, we chose to include it because all other responses from this participant were reasonable, and we felt it was possible that this contract was from one of the Affordable Care Act commercial marketplace plans, since they often don't reimburse very well. The maximum was $135. The median for most contracts was in the $60 range. The 75th percentile average ranged from $61 to $73.69 across the 5 contracts, and 25% of all managed care contracts were located under Contract 1. This graphic is my favorite. So if you're listening to this while you're driving, you might want to bookmark it somehow or pull over. Please don't be looking at it while you're driving. But before you really look at the numbers, take a moment to notice which region your state resides in, as it might surprise you. Because I'm from Kansas and Missouri, and we've always thought of ourselves as Midwestern, but we're in the Southern region. So it's important to know where you reside so that these rates make sense to you. The national average QZ rates came in at $58.62, ranging between $55.33 and $64.57, as I said in the previous slide, as compared to the ASA averages of $77.01. And wow, this is a 24% disparity. Regional comparisons were similar, with rates the highest in the Eastern region for both providers, with QZ averages of $63.97 versus ASA rates of $86.73, and they were the lowest in the Western region, with QZ rates averaging $56.36 versus ASA $73.10. So the largest disparity was seen in the Midwest, with a 27% difference in rate versus the Southern region that showed a 19% disparity. Now that we've concluded Section 1 and our discussion on rates, let's turn to Section 2 and look at our survey results as they relate to provider contracting experiences. The second section of the QZ survey focuses on other factors contributing to CRNA contract negotiations, and results were reported by 40 out of 41 respondents who participated in this part. 62% reported negative payment adjustments based solely on the provider's licensure or the QZ modifier. And this is important because this is an adjustment that happens on the back end. So a physician-led practice may be reporting a rate in the ASA survey of, let's say, $100, but that rate is only received when they are billing under medical direction. When they submit the claim under QZ, they may only be receiving $80 because there's a 20% rate reduction being placed on the back end. 25% were denied plan participation due to services deemed outside the CRNA scope of practice, and 20% reported denials in reimbursement for pain management services due to inaccurate payer perceptions of the CRNA scope of practice. 27% reported they were excluded or denied participation in state-authorized plans. And most of these were reported by respondents practicing in the Western region. Lastly, more than a quarter experienced payer obstruction to timely renegotiation of contracts, but I will say that typically happens to anyone negotiating with commercial payers. They typically like to wait as long as they can to avoid making that adjustment. Next question is, how does this impact CRNAs? Well, aside from the obvious reduction in our take-home pay when billing fee-for-service, everything we ever thought we knew about cost efficiencies have to be revisited. Many of us remember when Hogan published that first cost efficiency simulation of anesthesia delivery models in the Journal of Nursing Economics back in 2010. And this study, if you recall, was truly groundbreaking for CRNA practices because he created a practice simulation framework that he was able to formulate cost efficiency comparisons between the delivery models. Now, these simulations showed CRNAs to be the most cost-effective delivery model by far. Hogan's simulation was updated later by Lewin in 2016 to account for different payer mixes and salary increases, but both studies to this day receive wide acclaim and are cited by literally hundreds of articles claiming that CRNAs are the most cost-effective simply because they're able to perform the same service for about half the cost without any loss in revenue. These simulations provided the basis to promote all the economic benefits associated with CRNAs, such as replacing medical direction anesthesia teams with the efficiency-driven anesthesia delivery models where staffing consists of fewer anesthesiologists and higher numbers of CRNAs. And by doing this, the facility could optimize profitability by decreasing operating costs without any loss in revenues. This is a simple concept, right? But the problem with these strategies lies within the revenues. Our study finds that CRNAs only receive about 75% of the anesthesiologist's rate. So if this is true, then it follows that revenue cannot possibly stay the same. So what happened? It's simple, really. The simulation models failed to consider one critical variable, and that variable was payer discrimination. Before we go any further, let's review a little and go back to my earlier statement about the ASA commercial rate benchmarks. In the beginning of this presentation, I pointed out that the ASA surveys aren't reflective of CRNA rates because these surveys make no distinction between rates associated with the delivery models or provider types in the questions related to commercial rates. In addition, these surveys are selectively targeted at anesthesiologists through their ASA membership, and no CRNAs billing fee-for-service are asked to participate. Consequently, these rates only reflect rates negotiated by physician groups and are more often reflective of rates when medically directing, since no questions in these surveys focus on rate variability or adjustments when billing under the QZ modifier. Yet most, if not all, of the cost efficiency comparisons performed over the years relied on the ASA reimbursement rate when comparing revenues across all delivery models. Remember, we didn't have benchmarks until now to show any measurable disparities. The underlying simulation framework was structured according to Medicare rules where both providers were paid the same. And as such, all anesthesia delivery models, including the CRNA alone model, used the same commercial rates when calculating revenues. The simulations would be perfect if payers were complying faithfully with the non-discrimination provisions of the Affordable Care Act. But the fact is, the only time these simulations can show the CRNA QZ delivery model as the most cost efficient is when payers reimburse both providers non-discriminately or when the patient population is 100% Medicare, as shown in this 2018 study conducted by Centena and Hogan. And I'm not personally aware of any facilities that exclusively caters to Medicare patients. So my question to you is this, and this is important. How can a study accurately compare cost efficiencies between anesthesiologists and CRNAs without first establishing commercial rates specific to each provider? The answer is you can't. Since Hogan and Lewin did not consider the variability in commercial rates between provider types, the results are not reliable and they're not predictive. Wouldn't you like to know how these results impact our overall cost efficiency? I thought you might. I know I did, and I thought you might like to see a step-by-step of what we discovered. But first, let's start by reviewing the original framework, and we can get a better understanding as to how our substitutions come to impact overall cost efficiency. The Lewin simulation held key parameters constant. The payer mix was allocated according to the percentages shown here, and the rate assigned for commercial payers was taken from the 2015 ASA survey. Lastly, Lewin included the 2015 salaries as shown here. On the top right, I show substitutions to salary as reported by the Medical Group Management Association, and below the salary substitutions, you will see three tables. The first table shows the original parameters from the Lewin study along with the payer mix. The commercial payers contribute 46% of the overall payer mix with a rate of $68 that you see highlighted in orange. This rate, again, was the amount reported by the 2015 ASA Commercial Rate Survey. And you can see that the overall payer mix average rate per unit was $41.27, which is also highlighted in orange. The two tables below it are separated by provider type, and each contain the same payer mix. You can see that by making the provider-specific commercial rate substitutions of $77.01 for physicians and $58.62 for CRNAs from our 2019 QZ survey, we have two very different payer mix rate averages. The physician average payer rate becomes $45.41, while the CRNA average payer mix rate is much less at $36.95. Now that the variability in rate has been considered and the salaries have been updated, we can more accurately apply them to the simulations. But before we look at that, let's review the baseline results as Lewin presented them in 2016 so that we can see just how much these variables affect the outcome. The 2016 Lewin cost efficiency comparisons we will be comparing to are based on an outpatient setting with 12 stations running 7 cases per station per day. Now, the first column shows the delivery models, and we included anesthesiologist alone, CRNA alone, and medical direction at a 1-to-4 ratio. The second column shows the revenue each model generated, and you'll notice both the CRNA and anesthesiologist models are generating the same revenue, but the medical direction model does show a slightly higher number, and since the study stated Medicare rules were being followed, I wondered about this, so I decided to ask Paul Hogan himself, since he created the original framework that's been used on these simulations, and he said a few adjustments were made to the total units when medically directing to account for additional time spent waiting for the anesthesiologist to be present for induction and emergence. The next column to the right shows the costs, and it's easy to see why CRNA delivery models are more profitable since CRNAs are able to provide the same service for about $2.16 million less than anesthesiologists alone and $400,000 less than the medical direction. So as you can see, the differences in cost between CRNAs and both other delivery models are the reasons the CRNA delivery model is so much more profitable. You can see that these differences are directly tied to profitability in the net income column. But remember, and this is important, these calculations use the same commercial rates for both CRNAs and anesthesiologists when establishing revenue forecasts for these models. The next simulation will show what happens when rate variability is considered. In order to differentiate between these two simulations when discussing them, we will refer to our cost comparison as the Covillo simulation. Catchy, right? The 2019 Covillo simulation accounts for the variability in reimbursement where an entirely different story unfolds, where the ending just isn't quite as sweet. The Covillo simulation calculates the revenues in each delivery model by utilizing the provider-specific rates by payer mix that we previously showed you in those key parameters. When the provider-specific substitutions are placed into Hogan's simulation framework, you can immediately see the dramatic impact on the CRNA revenue. Both providers no longer show the same revenue as they did in Lewin's model. Instead, CRNAs are now showing a revenue reduction of about $2.4 million when compared to the medical direction model. When you turn to the cost column, you notice the changes due to salary increases. And anesthesiologist salaries have increased by 32% as compared to a 21% increase by CRNAs in the years since the Lewin study was published. But even though salaries have increased, CRNAs are still about $3 million less in expense when compared to the anesthesiologist alone, and nearly $1.4 million less when compared to medical direction. Although CRNA models continue to do significantly better than the anesthesiologist alone model, the drastic disparity in revenue totally offsets the savings associated with the lower CRNA salaries. This massive disparity forces CRNAs out of the lead position for cost efficiency, allowing medical direction models to take their place by the tune of about $1 million. The next slide summarizes this a little better. Here we can see the reason why the CRNA delivery model has lost their competitive advantage in overall cost efficiency when comparing CRNAs to the medical direction models at the 1:4 ratio using the 2019 Covillo simulation. The first row shows the CRNA cost savings of about $1.4 million as compared to medical direction, but this is not enough to offset the $2.4 million revenue loss this model receives, which is the reason medical direction models end up with a higher net income, even though the physician delivery model costs more, to the tune of about $1.4 million more to implement. The bottom line is, when payers reduce CRNA revenues, they are disincentivizing hospitals from implementing cost-effective strategies and basically sabotaging these efforts. This contradicts the Affordable Care Act. Maybe we should call it the Unaffordable Care Act. The impact these findings may have on healthcare delivery really hasn't been studied, since this is the first time anyone has ever shown QZ benchmarks or challenged the validity of efficiency simulation models. But I can tell you what I think. QZ is estimated to account for about a third of all claim submissions, so you can imagine payer discrimination economically impacts any setting where CRNAs work or even occasionally provide medical direction. This includes hospitals, outpatient centers, mixed practice groups, like the 56% of respondents found in our study, as well as the independent CRNA groups. We've already seen how payer discrimination disincentivizes hospitals from hiring less costly CRNAs, yet the higher costs associated with medical direction models often require hospital subsidies. When a system rewards higher costs and inefficiencies with higher revenues and penalizes cost-efficient delivery, the system has been broken. Hospital subsidies will continue to rise while CRNA practices will no longer be in a position to compete. Competition in the marketplace has already been impacted. I know our group is having a heck of a time competing with these groups, as it has become nearly impossible to recruit staff with comparable benefit packages. Finally, access to care is always affected when CRNA services are limited. If CRNAs can't generate sufficient revenue to maintain market viability, their doors to their practices will close, and the patients will lose access to care. The Affordable Care Act requires commercial payers to reimburse providers non-discriminately, regardless of licensure, when performing the same service. And the intent of this act was to challenge the system to improve processes designed to reduce overhead and increase productivity without any loss in revenue. Hospitals and surgery centers are rising to that challenge by turning to efficiency-driven anesthesia delivery models where higher numbers of CRNAs can more flexibly provide essentially the same services while decreasing overhead expense. But when payers discriminately lower CRNA rates, they are effectively sabotaging these cost-saving efforts by redirecting these savings as profit for themselves. And the Affordable Care Act wasn't intended to serve as a profitable windfall for payers at everyone else's expense, and it certainly wasn't meant to prevent CRNAs from freely competing in the market. Currently, there are no regulations in place to enforce payer compliance with non-discrimination provisions. Instead, payers are trusted to use good faith efforts when interpreting the law. The findings from this study show that anesthesia providers are not equitably reimbursed, and the 24% rate disparity, along with all the other payer tactics used to limit CRNA participation, as we saw in this report, is evidence that payers require more than just a little good faith to regulate their behavior. So let's take a few minutes to sum this all up with 4 takeaway points. The first is the national average payer rate for CRNAs was $58.62 per unit as compared to the ASA rate of $77.01. There is a 24% disparity in reimbursement reported between the two providers, even though CRNAs and anesthesiologists are providing essentially the same anesthesia service. The second takeaway point reveals a misalignment between payer actions and those intended by the Affordable Care Act, which negatively impacts QZ reimbursement and imposes an unfavorable, disadvantaged, or prejudicial position for CRNAs when negotiating contracts with payers for anesthesia services. The third point is discriminatory payer practices were observed. Exclusion from network participation in commercial and state-authorized government plans, negative payer payment adjustments specific to QZ claims, payment denials related to licensure and scope of practice, and obstruction to timely contract renewal. And finally, the last takeaway point is that QZ services are prevalent in all practice settings. So when payers discriminate between providers by targeting CRNAs for reduced rates, they impact revenues across all practice types, not just CRNAs. If you remember, 56% of the respondents in this study reported on behalf of mixed practice settings in which 68% of all claims were submitted under the QZ modifier. So you might be wondering, what can we do? Well, we've come up with 4 recommendations. And the first is to perform commercial reimbursement surveys every year, just like the ASA performs, and make these rates available to the members. The second is to validate these surveys by performing an actual reimbursement claims analysis to test the validity of the yearly surveys. And this data can be obtained from any of the multi-claim databases such as Optum or the Healthcare Cost Institute. And the third recommendation would be to pursue legislative efforts aimed at enforcing regulatory payer compliance with real monetary consequences. And finally, recruit stakeholders to assist in these advocacy efforts. The American Hospital Association might be a great place to start. As you know, hospitals that employ anesthesia groups are seeing these same reductions. If you recall, our survey showed 56% of respondents were from mixed practice settings. So with that understanding, it might not be unheard of to gain some anesthesiologist support as well. And finally, having attempted all other remedies, the Federal Trade Commission is tasked with ensuring markets remain free and fair. As a last resort, we may need to call upon them to end commercial payer anti-competitive practices. This study has opened my eyes to the drastic impact when payers discriminate. And although you may not have been surprised at the disparity seen, I'm guessing you didn't quite expect the results to impact our cost efficiency models as much as it did. Our study results show a misalignment between payer practices and the Affordable Care Act The disadvantage of CRNAs in the marketplace disincentivizes hospitals from initiating cost-effective strategies, economically impacts all anesthesia practices alike, increases overall healthcare costs, and reduces access to care. But hey, let's look at the bright side, right? We now have benchmarks that have never before been established. We have evidence that shows that payers are reimbursing CRNAs significantly less than anesthesiologists, and we can quantify these disparities. So, the biggest takeaway is that we now have the evidentiary basis that supports the priority of enforcing regulatory payer compliance to ensure that markets remain free and competitive. So what are we waiting for? Let's get it done. I want to thank you all so much for listening to this presentation, and I've included some of the references at the end for your convenience. I realize that was a lot of information to be giving over such a short period of time, so if you have questions, please feel free to reach out to me or any of the other members of the research team. And until next time, have a great day, and thank you for watching.